When we're looking at asthma, asthma is an acute thing that's a chronic condition. So an asthma attack in itself is acute, meaning that that patient is experiencing that right then and there. More often than not, if you make it to adulthood with asthma, that is now a chronic condition with acute episodes. And so asthma by definition is going to be caused by an irritant, and the airways are going to respond by whatever the perceived irritant is, and it's going to contract the smooth muscle in the bronchioles. It may thicken over time, and then it's going to start secreting mucus to try to track that irritant or trap that irritant in the mucus so that it's not actually touching the tissue. You can almost think of this as a response similar to allergies. It's very much similar, although not so much as in anaphylaxis. Now, throughout asthma, the wheezing is heard on expiratory or the exhalation phase, and asthma is actually a gas trapping phenomenon. They can generally kind of take that breath in, and it's trying to get the gas back out that is causing the extra issue, and so they become hypoxic because they're unable to get that CO2 offloaded back out of the breath out, and their inhalation will seem relatively normal. These are allergic reactions, exercise or stress, or upper respiratory infection induced, and the typical patient is going to know that they have asthma and they have the appropriate medication for it. They may not be responding to the metered dose inhaler that they're prescribed for it, and which results in us giving them a much larger dose so that we can override the symptoms. Your patient is going to have a lot of history based on how they are able to deal with their asthma. One of the big things that you want to know is if they get so bad in an asthma attack that they've been intubated. The more likely they are to have been intubated, the more likely they are to be re-intubated in those same attacks. And that's something that ALS needs to be involved in. So when you're dealing with somebody who has asthma and they're telling you that they have asthma, obviously give them the medication as quickly as you can possibly give it to them and get it on board, but you really want to get that detailed history. That's not a patient to take lightly, and when you see an asthmatic with a low O2 sat, you're already behind the cuff. We're going to roll into anaphylactic reactions, and this is severe allergic reactions, which is going to show or manifest in two or more things, right? And so that's a narrowing of the airways or difficulty breathing, hypotension, and then swelling or urticaria around the mouth and face, and it could be all over the body, but we're really specifically looking for that hypotension and the difficulty breathing. A true anaphylactic reaction is a real emergency, and the appropriate treatment for that is epi. There should be no reason that anybody should be scared to give somebody epi if they recognize that somebody has anaphylaxis, and if you're waiting until you see all of the symptoms that you want with the respiratory issue, the hypotension, and the swelling and widespread splotching of the skin or the urticaria, you're already probably too late. Benadryl and things like that aren't really going to actually work very well. They take a little while to get on board, and albuterol will give you a little bit of time, but if that person's already closed down in the respiratory tract, it's really hard to deliver that medication. Epi is going to approach this particular disease process from both sides. It's going to cause vasoconstriction, which will increase blood pressure and open the smooth muscle in the bronchioles. So it should be a first-line drug for anybody that sees anaphylaxis. Spontaneous pneumothorax. This is somebody who perhaps twisted a different way or moved something or coughed, and they blow what we call a small kind of like a blub or a small tear in the lung tissue. And unfortunately, I don't have a good video of this, but perhaps we can kind of dig something up later on. But you can actually see as this air leaks out of the tissue into the pleural space, think of a lung basically sitting inside of a closed off clear trash bag, and as you're ventilating it, air is escaping out of the lung into the trash bag, and then now that air is compressing the sponge-like tissue of the lung. These can be pretty life-threatening, and it's not something that you can treat, but understanding a pneumothorax and that there would be like one side of the chest would have decreased breath sounds. There's really no associated trauma to it, but you know that you have decreased breath sounds throughout that entire side of the chest, right? Like the left lung or the right lung is actually decreasing, and that person's becoming more dyspneic and their O2 sets are starting to drop. You recognizing that and getting in contact with ALS is significant to their survival. Here's a couple of the causes for spontaneous pneumothoraxes, and that's chronic lung infections, which will make their lungs weak because of the inflammation. They were born with weak areas of the lung. Emphysema, because the structures are now changed and they've become weakened. And then asthma, because they're actually air trapping, and so they can actually build up a pocket of high pressure in that particular tissue. Tall, thin, healthy males are highly at risk, and mostly just because of the way that they're conformed into the chest cavity. This is discussing the kind of complaints of somebody who may have a spontaneous pneumo. They're like immediately dyspneic, right? They've had that sudden shortness of breath that didn't have any kind of history that brought on with it. And then they will tell you that they have chest pain, and it's usually very pinpoint. They can point to exactly where the pain is, and the breath sounds become absent, or they're decreased and decreasing on the affected side. Now, these patients can become very problematic because they will become pale, diaphoretic, and tachypneic. And this is because the increased pressure can actually push the heart against the vena cava, slowing blood return into the heart, which is going to make a compounding factor on why they're going into shock, because one, they're not able to onload and offload oxygen at a normal rate, and two, they're decreasing their blood flow. Now, if they're pretty severe, they will probably show up with altered mental status because they're hypoxic and their perfusion is completely shot because of the compounding of both the gas exchange and the blood flow. They'll be cyanotic because they're now unable to actually get oxygen onloaded. They're going to start building up some CO2 in any of the bloodstream that they actually have that's moving. Tachycardia, and this is resultant because the heart is responding to the hypoperfusion and it's trying to compensate. And then you can hear the unilateral, meaning one side, decreased breath sounds, and what we call a local hyperresonance. And so this is also something that you can hear on your COPD patients, but because there's now a large pocket of air there, you can tap on the chest. You're listening to it with a stethoscope, obviously, and you can almost hear that drum-like resonance to their chest wall. Instead of that solid thud when you would tap on a normal chest, because that lung tissue is expanded and filling the space, you'll kind of get a very soft like drum sound to it. Tracheal deviation is almost never observed, and if you do observe it, it should be a pretty late sign, and that means that we're really in a bad way. Again, on this particular one, these symptoms that are indicating a spontaneous pneumo really need to have ALS care and or the hospital immediately. So you're going to have to look at that and tread lightly. Can you rendezvous with somebody who can do a needle decompression, or can you get to the hospital in a shorter amount of time? Regardless, it's beyond your scope of practice to be able to deal with this other than ventilatory support. Pleural effusion is a collection of fluid outside the lungs. It could be one or both, and it will actually start to compress the lung, and the fluid will cause dyspnea. And this could be anything from irritation to infection or cancer, but basically we're looking at something is causing plasma or other interstitial fluids to come between the lung tissue and the actual pleural membrane. And so this can occur over time, or it can happen fairly suddenly. And in previous classes, people have asked, well, like, what does a pleural rub sound like? And the only way that I can describe this for you guys is if you take two rubber or like two balloons and you try to rub them together, you can hear that kind of friction bucking noise. If you hear that, that's the only way I can describe a pleural effusion. When you hear it, you'll know it's completely different from any other adventitious lung sound that you've heard before, and it should be self-evident. So just know that that's the only way that I can describe it for you, and hopefully if you do hear that, that you understand it and recognize it early. Okay, so now we're going to talk about pulmonary embolism. This is really, really hard to diagnose in the field, but there are some telltale signs. And again, this is a pulmonary embolism that is a blood clot that's in the pulmonary artery or arterioles. This is something that's traveling into the lungs, and it gets wedged or lodged into a smaller vessel and blocks off blood flow to a certain portion of the lung tissue. And depending on how large this clot was, could ultimately tell you about how much of the lung is actually involved. Now, the problem with this particular condition is that this patient is going to be short of breath, and you're going to have zero reason why. You're going to listen to lung sounds, and you're going to hear gas exchange everywhere. It's not going to show up in some kind of stethoscope auscultation of the lungs, and they are going to rapidly breathe because they're really, really struggling to get oxygen to onload and offload, into the cells. You may see a decrease in O2 sat. Their heart rate's going to be up. So just know that in particular patients, there are going to be high-risk events. This could be anybody who suffers from DVTs. They have a history of AFib, but there should be something that's telling you that there would have been a clot that formed that has made its way either from the heart into the lungs or from the legs through the heart into the lungs. And I shouldn't just say just legs. I mean, from anywhere in the body. But it is, if you have a pulmonary embolism, it came from the right side of the body, and now it is wedged into the lungs before it returns oxygenated. This is a pretty good picture and a flow chart of pulmonary embolism, and you can see it's damage to the lining of the vessels, right? They broke a clot off. They have some kind of reason for coagulation, which is they formed a spontaneous clot, or they have slow blood flow in a lower extremity, which is when we generally say somebody may be at risk for pulmonary embolism. Here are some of those risk factors again: immobilized legs, recent surgery, pregnancy, oral contraceptives, infection, cancer, sickle cell anemia, prolonged inactivity. They're bedridden, and again, they're going to have that acute dyspnea. They're going to have the acute pleuritic chest pain. And really, just understand that this is going to come on and you're not going to see a lot of other signs. It's going to be based on your history that should trigger you into thinking pulmonary embolism. Again, these patients are not going to have decreased lung sounds. They're going to be moving gas freely. It's the actual blood supply into the lungs and back out of the lungs that's being disrupted. Short talk on hyperventilation, and that's somebody that's breathing too much or over breathing so that they actually blow off too much carbon dioxide. And it could be a life-threatening illness if it's not corrected. The body will attempt to compensate for this lack of acidosis by actually causing a fainting spell. And if they are not breathing enough, the acid will actually build up and the CO2 levels rise. And so a lot of these things are based in that homeostasis kind of pathway where we're trying to maintain a normalcy. In regards to that, tachypnea without the actual demand for the increased oxygen causes respiratory alkalosis, right? And this is low CO2 levels. They'll become alkalotic, and they will tend to have anxiety-like symptoms. They'll get dizzy, numbness, and tingling to the mouth and the face and the hands and feet as well. And again, ultimately, if these people continue to breathe at that rate, they will generally faint. So we're going to talk about obstructions of the airway, and you guys all have heard me say multiple times in lab or in some of the other lectures, when a patient is flaccid or unconscious, typically the tongue will relax, all the muscles in the body relax, and that tongue will roll back and block off the airway. And so that's where we get that snoring respiration. So we want to do that jaw thrust, tongue lift, and try to get it up out of the way. The NPA is generally the favored first tool to use. It's a good indicator whether or not that patient will tolerate an OPA, and it's fairly non-invasive. We always want to move least invasive to most invasive, with head positioning being the first, right? The rule of twos, which is 2 inches of head elevation, putting them into the sniffing position, which is the head tilt chin lift in conjunction with head elevation, and then start to use our basic adjuncts. So there are plenty of things that can actually cause respiratory problems by inhalation injury. And inhalation injury can be anything from superheated gas, right, like being in a fire, or smoke inhalation, or any number of chemicals that could be inhaled that would cause some kind of pulmonary reaction. And For the most part, if there's any kind of acidic or caustic kind of substance involved in what you inhaled, the body will actually respond in kind, and it will actually try to kind of flush and move that stuff away from the tissue, which may be causing necrosis. And these people are going to have that flash pulmonary edema as well. So we're going to talk about cystic fibrosis. This is a genetic disorder of the endocrine system, and it actually targets the respiratory and the digestive system. What generally tends to happen is the lungs have excessive secretions, and eventually over time fibrinogen starts to build up in the lung tissue, which is taking away the elasticity and obviously the surface area. These people are actually fairly fragile, and there is no real cure for this, and eventually they will ultimately end up needing to have a lung transplant or both lungs transplanted. They can have wild-like variants in the symptoms, from congestion to asthma-like complaints. They have respiratory insufficiency, and you're looking for signs of respiratory infection. And not that you're actually going to know if they have intestinal blockage, but people with cystic fibrosis generally know that they have it because it's a condition that's been with them since they were born, or very early in childhood when it was diagnosed, and they've been dealing with it for quite a while. They'll be able to help direct you in the best way to help them, which is supporting their ventilatory response and giving them oxygen.